everybody. My name is
Thank
Dr.
you
P.
for coming.
Thank you. Thank you for having me. Again, my name is Dr. P. Do surgery. I did a trauma critical care fellowship, so that's one of the reasons why I'm doing this. The last time I think we did a pigtail catheter, so a big jump from a pigtail catheter to a open ED thoracotomy. So first of all, one of the main things that everybody has to know is when we do an ED thoracotomy, and we don't do an ED thoracotomy for everybody. The only indication for an ED thoracotomy is one, the patient has a penetrating injury to the chest, and two, the patient is coding on the way or has just coded. So you get, the dispatch and, oh, I got a stab wound or a gunshot wound to the chest, and oh, he's hemodynamically stable, we're on our way. So we call out a trauma stat, and then they give you an update, oh, he's starting to code. So within 10 minutes of coding and the patient gets here, then you do an ED thoracotomy. If the patient has vital signs when he gets here, you don't do an ED thoracotomy. That patient, if you're worried about a chest injury, that patient goes to the operating room. But to do it here, the patient has a penetrating wound to the chest, you're worried about bleeding, and the patient has coded within 10 minutes of arriving. So that's when you do an ED thoracotomy. The reason why is because the purpose of an ED thoracotomy is you want to fix the hole that's causing the bleeding, whether it's in the lung, whether it's in the heart, and if it's over 10 minutes, then that patient does not have a chance of surviving. If it's less than 10 minutes, then they have a very slim chance where you can potentially put your finger in the hole in the heart or the lung and stop the bleeding and get the patient stable enough to go to the operating room to get a repair. So that's the reason why we do ED thoracotomy. That's the indication. So if you have somebody who came in with a blunt trauma, a really severe motor vehicle accident on I-93, and they come in and code, thoracotomy is going to be not necessary. So that's when we do ED thoracotomies. Now, the number one thing that you absolutely have to remember when we're doing an ED thoracotomy is, the patient has a very slim chance of surviving. Don't worry about that. It's very hectic. Everybody's all running around. There's blood everywhere. So don't get stabbed. Don't get poked. Don't get, that's the most important thing. There's like knives flashing all over. The surgeon's like, cutting through muscle and skin and whatnot, and there's like bleeding everywhere. But in that case, there's a very high chance that somebody is going to get injured. So that's the most important thing. Be careful. If you're worried, then just take a step back and just let the surgeon do whatever he wants to do, because I don't want anybody to get injured. It's not worth it. So that's the second most, or actually the first most important thing that you have to remember. Now, so they asked for a thoracotomy tray, and we're going to do the thoracotomy
thing.
Before we get the thoracotomy, another thing that needs to be done is, one, absolutely the airway has to be intact, so the patient needs to get intubated. And number two, if the patient is bleeding and we're doing the ED thoracotomy because we want to fix whatever hole, once you open that chest, you're going to lose the tamponade. And then the patient's blood pressure is going to, if he didn't have a blood pressure or if he had a small blood pressure, it's going to drop even more. And then now you have an untamponaded hole, it's going to bleed, and it's called audible bleeding. You're going to hear the gush of blood out. So you have to resuscitate, and you're going to have blood, you're going to have fluids just dumping into the patient. Now, if there's a hole here, you need to get the transfusions that you're giving the patient to the heart. So the heart has to pump it out. You don't know where that injury is. So you need two, preferably Cordises, one above the diaphragm in the subclavian or the neck, and one below the diaphragm in the femoral veins. So those two preferably we would like to have, and the patient is getting fluid and blood getting dumped into. Now, and then we proceed with the thoracotomy. So I think the main purpose of this is to just look at the instruments and see what is there and what we need. This isn't a sterile procedure. It's here. So what we do is we just take a bottle of betadine, we just dump it and pour it on the patient's chest. It's not sterile. And then here's the knife handle. You put a 10 blade, and then you hand it to the surgeon, and the surgeon is going to make a. Well, we try to start off with the anterolateral left thoracotomy. So the patient is lying here, and we start off between either the 4th or 5th intercostal space, which is around the nipple line. And that's where we get the most exposure. What I like to do is I like to start a little bit laterally, because the reason why the patient code, we don't know. It could be from a hemothorax, it could be from a tension pneumothorax, but the patient's coding, we don't have time to get an x-ray, we don't have time to fuss around with a small chest tube. So I take a knife and I just make 2 passes, and I make a small cut laterally. If I feel a gush of air and it's from a tension pneumothorax, then I wait to see if the patient regains vitals. If it's not, and it's blood gushing out, then I proceed with the anterolateral thoracotomy, which is from right next to the sternum, all the way laterally, to preferably all the way to the bottom of the stretcher. So I make 2 passes, and I go just above the rib cage, because underneath the rib, you have, when you eat, baby back ribs, there's a little groove there, and it has like arteries and veins and nerves that go underneath the rib. So I go above the rib, and in the 4th or 5th intercostal space, just beneath the nipple line, and then I open it up. So I make 2-3 passes to try to open it up, and then you can use any one of these clamps or whatnot, but preferably we don't want to use all this stuff. We just make the cut, and then while somebody is retracting a little bit, we put this in. It's called the finishetto, and you put these into the rib cage, and then you turn it, and then it opens it up and it retracts, so you can see the pleural space. So once you get in, what you're trying to find is the blood. Where is it bleeding from? So if there's a hole in the heart, you occlude the heart, the hole. If it's about 1 centimeter, you can occlude it with your finger or a piece of gauze, so they're going to ask for that. If it's a little bit larger, you can occlude it with a Foley catheter, so always have a Foley catheter around. So you put it in and then inflate the Foley catheter and then pull it up, it's going to occlude the hole. You always have to clamp the Foley catheter because blood is going to come out through the Foley catheter. And then once that's done, you resuscitate the patient, get the patient stable, semi-stable, and then you take the patient to the operating room to fix the hole. And once this is open, there's a lot of blood gushing if there's a hole in the heart or even in the lung. You can't see anything. It's just blood welling up, and it's in a pool of blood. You can't suck out the blood fast enough, and there's partially clots here and there, so you can't see anything. So once this is open, what we do is we're going to need a lot of pads, and then we just start packing. And then we start packing. Once it's packed, hopefully the patient will regain some vital signs with the help of the resuscitation, and then we slowly take the packing out to figure out the hole. Sometimes if the patient's stable enough, then we try to get to the operating room to try to figure out where the hole is. If you're able to see the hole, you plug it. But again, sometimes that's very, very, in theory it's good, but in reality it's very, very difficult. So all I need is blade, finish up, and pads. Now all this other stuff are, so we spoke about an anterolateral thoracotomy. Sometimes you can't see everything with just the left lateral thoracotomy. You can see majority of the heart, you can see the left lung, you can sometimes see the left subclavian artery, but you don't see the right side. And if you have to extend the thoracotomy toward the other side as well. So I do the same thing. I make a cut laterally, make sure it's not a tension pneumothorax, and then I extend it. So the incision will go across like this. In the mid portion, sometimes you have to resect the xiphoid process, and you can do that with either this or this is called a Lepsch mallet and knife. You can do it with this, but this is normally used for a sternotomy. In the operating room, thoracic surgeons use a sternal saw, but here sternal saw is very, very dangerous. You know, I had a thoracic surgery attending who lost her finger because the fellow went through her finger with the saw. It just goes right through like butter. So what this is there's a handle and there's a blade on this side. It's fairly sharp. It's not sharp to, you know, cut your finger, but it cuts through bone pretty well. So make a cut just underneath the sternum, and then we put this in, and then we lift it up so that we lift up the sternum, and the sternum is like this. And then take this mallet, and then you do that to cut the sternum up, and then you do an open sternotomy. Again, a sternotomy in a hectic situation is very difficult. It does give you the best exposure to the chest, but I highly doubt that there's going to be somebody who's going to do an open sternotomy in the emergency room. So we usually do a left thoracotomy. So this we don't use a lot, but if there's bone, really hard bone that needs to be resected, it works well. This also works very well. It goes through bone and it can cut ribs. So if you're having trouble at the Outback Steakhouse, you can.
What's that one called?
The scissor?
Just what would you call it if you were asking?
Rib cutting scissor. Alright, so there's a bunch of other clamps which we really don't need or need to know the name of, but these are Satinsky's clamps. They're used to clamp, they're atraumatic clamps. They're used to clamp like the aorta. I like to use this to clamp the aorta. This is called a DeBakey clamp. Looks like this, very long. So we do the thoracotomy, and there's no blood in the chest. There's no air in the chest. The patient is still coating or very hemodynamically unstable. And you look at the belly, and you're worried that there's blood inside the belly, and the patient has a lot of blood inside the belly, and the patient's bleeding from the belly. At that point, with the thoracotomy, what you can do is you go in and you feel for the spine, and then just above the spine, there's going to be your esophagus and your aorta. So what I do is, preferably, you just want to get this across the aorta, and you're going to stop the bleed, stop the blood that's going to go down to the belly, and hopefully the patient regains his blood pressure. Normally, we try to get it just across the aorta, but sometimes it's very difficult to divide the aorta and the esophagus. So, you know, it's okay to clamp the esophagus. I just go in and I clamp both, and the patient regains vitals. I take him to the operating room.
Dr. P, do you anticipate using pause? I know Dr. Jemis used pause to.
What are paws?
They were like these plastic things that when.
Oh, on top? No.
That's
during that time, it's too. I don't think somebody's gonna go like, oh, give me some pause and then we'll stick it. Yeah, I would just go in and try to clamp and go in there. Again, this is the Satinsky, same. It just has a curve, so sometimes it's easy to navigate areas. This is called the Dayball clamp, and it's also an atraumatic clamp, and it's used to pick up lung tissue. So if you have to retract the lung, you grab it and then you retract it. Somebody's holding it up so you can get underneath to clamp the aorta like that. So Dayball, Depsch, Lepsch. I've never used it before. This is DeBakey, or just a back. They're gonna ask, vascular clamp. Satinsky clamp. Also, they're gonna say vascular clamp, and you hand them this. No, not that one. So you hand them this one. Dayball. Usually, it's too much of a hectic situation to actually use the dayball very well. So, and then you have your assortment of scissors. These are called medicine bombs. Medicine bomb. Yeah, and the rest are just the regular old scissors and clamps. Any questions?
When you talked about the Cordis, what did you mean by that?
A Cordis?
Yeah.
So, when we put in central line for resuscitation, a triple lumen catheter is not a resuscitative line. What's better is bilateral 18s are much better than a triple lumen catheter. Because a triple lumen catheter is very small, it's very long, so you can't resuscitate or give fluid fast through a triple lumen catheter. some triple lumen catheters aren't even what's called power injectable, and you need a power injectable line to get a CT scan because the contrast that they push in through contrast CT scan, it's very, very fast. You can't push it fast enough with your hand, so that's why they hook it up to a machine, and the machine like pushes the contrast in for you. And when it pushes in, if it's not a power injectable line, the catheter rips open. But usually the triple lumen catheters nowadays are power injectable, so there's no concern about that. But because it's long, it's thin, you can't resuscitate with a central line. The central line is used for pressors. It's used for multiple medications, propofol, fentanyl, whatever. But it's not a resuscitative line. Resuscitative lines are bilateral 18s, which are small, but they're big enough to rapidly infuse, and they're very short, so you can get a very rapid rate in. But the Cordis is much bigger. It's like 8 French. Those, and they're Cordis kits. They're very thick. They look like a straw, and then you get them in, and you can resuscitate very, very quickly with a Cordis catheter. So preferably, if you have a place where there's a lot of residents and stuff like that, and they come in with a trauma stat who has a gunshot wound somewhere in here, and the patient's dropping their blood pressure, you're going to have one resident putting a line in the femoral, and you're going to have one resident putting a line in the subclavian, while the ED attending intubates, so everything is all happening at once. But it's hard, especially with the resources. So.
Everything that's on the structure was from the thoracotomy, correct?
Yes, correct. So first thing that we're going to need, betadine, and then the knife, preferably a 10 blade, and then the finish up. And then if there is bleeding, then you want the surgeon might ask for sutures. So there's a very long needle holder in these. There's an assortment of them. Needle holder. Yes. So silk is very sturdy. It's easy to deal with, and just big sutures. We really don't care what you hand us as long as we get the bleeding stopped.
And pretty much everything you need is going to be in this part, in the open thorax. That includes the betadine and the sutures and the knife and everything.
Yes, it seems like everything is there.
I would like to have that Cordis, that's what
I know, so we were looking, is this what you mean?
Yes, correct.
Okay, so let's show it. So that's an 8.5.
Yes, correct. It's just a central line, but it's just big and it looks like a straw. Through this, when you're doing vascular surgery, you can like put in guide wires and stuff like that. You can put in a central line through this as well. So if you have this in, and the patient needs to go to a CT scanner for contrast, these are Cordises are not usually power injectable. So what you can do is you can put a central line through this to inject the contrast. So those are the, but again, the survival rate after an ED thoracotomy is dismal. It's, depends on the literature, but I would quote it as like 2-3% the survival rate.
Thank you so much,
Yes,
Dr.
my
T.
pleasure.
Thank you.
Any questions? My email is in the system, so just send me anything. And